Again, my name is Josh Goodwin. I'm the doctor here at Regenexx Las Vegas. We're going to go through one of our just kind of basic overview webinars talking about regenerative interventional orthopedics. So a mouthful there, but really just looking at an alternative to orthopedic surgery and just how technology and understanding of how our bodies heal, we can take advantage of those processes to assist with treating orthopedic conditions. So this is one of our just general kind of overview, try to just educate people on some of the different options without specifically going into all the details of every single joint and every single condition. Talk a little bit about myself, kind of traditional treatment options, some of the specific things that we do, and then how do we at Regenexx Las Vegas make decisions and the process we use to educate people on what their orthopedic options are, specifically the Regenexx procedures. There will be a Q&A at the end. You guys can chat down some questions in that chat or the question and answer section, just so you don't forget them as you think of them. I'll probably not stop the webinar to address them in the moment, but at the end, we will have some time where I'll make sure I go through each question. There will also be some contact information for our education center. If you guys had more questions or wanted any more information. So we're going to go ahead and get started. Just walking through. Again, I said my name is Josh Goodwin. I'm a medical doctor. I did my training at the University of New Mexico. I grew up in New Mexico in Albuquerque and stayed there for medical school. I am board certified in a specialty called physical medicine and rehabilitation, and fellowship trained in sports medicine and interventional spine. I've been with Regenexx for really since 2015, and I've been doing some regenerative medicine since 2014. I'm a co-author on a review article for treatment options, specifically different stem cell treatment options for low back pain and disc degeneration. So what are we talking about? So really, everything that we focus on here is orthopedic based. So that's your muscles, tendons, bones, your joints, your spine structures. And as you can see on the screen, hopefully, these conditions affect people of all ages, whether it be traumatic or as we age, getting a little bit more degenerative, overuse, wear and tear type musculoskeletal issues. But they start to affect us as we age and start to make up a higher percentage of patients as we age. They do cost a lot of money to both direct and indirect costs to treat these conditions. And many of us are obviously on here likely because of an orthopedic problem, or at least know somebody with one. So they're going to affect most of us throughout our life at some point. Many of us may be aware of some of the current treatment options, whether it be, getting your ibuprofen and a Aleve medication to get the day going, or after exercise or activity, getting sent to physical therapy, using bracing, just to help assist with some support, getting your steroid injection or your cortisone injections, or getting surgery. So these are, some of the more traditional things that most people have been exposed to if they've ever, sought out care for an orthopedic condition. What's not always discussed when, we're handing out prescriptions or making recommendations on different options, even simple things like your ibuprofen or your Aleve medication or your prescription meloxicam or Celebrex, these all carry risks as well. You may or may not know they're associated with, deaths every year, heart attacks, strokes, kidney issues, stomach ulcers. And a lot of this is dependent on the specific drug and the length of time and the dose that people take it. Not on the screen, but there's some data coming out to show that chronic use of these medications is also associated with increased arthritic pain over time. So they may actually be making our joint pain worse the longer that we take it. So just things to consider. Obviously, they can be helpful in the short term and can be used as such, but when we're looking at them long term, we have to always weigh the risks and benefits. Other injection-based modalities that people get exposed to sometimes is cortisone or corticosteroid injections. These can be given oral or through injectable ways. These are very strong anti-inflammatories, and they can help improve pain associated with inflammation or osteoarthritis or tendonitis, other inflamed tissues. We're not always told about some of the potential complications. So if you're diabetic, it can increase your blood sugars. Some people are sensitive and can gain weight, flushing, anxiety. We know that it's focally toxic to your cartilage tissue, tendon tissue. We know that it can be associated with bone issues like acceleration of osteoporosis, weakening of bone, and as we can see down here, acceleration of your osteoarthritis, be associated with insufficiency fractures, osteonecrosis, and joint destruction. And so while they can be helpful in the short term, the repeat exposure can be detrimental to the long-term health of your joint. And one of our, philosophies is to help preserve your tissue. And one way to do that is to avoid cortisone injections. And again, we'll talk about some of the things that we utilize instead of corticosteroid injections when we can. So just some additional studies showing that these injections for hips and knees can be bad, and that it increases your risk of knee replacement by getting knee steroid injections. As things progress, obviously some people need different types of surgeries. When we're looking at spinal surgeries, these are probably one of the surgeries with one of the higher associated complication rates. And a lot of future progression and increased risk of future surgery. So depending on the age, complications can be quite high, and can include infection, tears, nerve injury, vascular injury, the screw being put in the wrong place, death from anesthesia or other complications. And so anytime we get to the point of surgery, we just have to weigh the risks and benefits and remember that we're opening the door to all of these potential complications. Now, sometimes it's the right choice, sometimes it's the only choice, and we have to accept that possibility. But if it's a condition where we might have some alternative choices, that's when we start to really have to weigh the risks and benefits and all of these potential complications. If we look at other common procedures like knee replacement, it can have a 16% complication rate to include death, infection, pulmonary embolism, repeat surgery, scarring of the joint that might need intervention. We've seen people recently that have just continued to have like pain and swelling after their joint surgery. Knee arthroscopy, a little less invasive, so carries a lower complication rate, but still is associated with different complications. And we have to remember that surgery is not always the cure for the problem, because not everybody gets back to full function. And so in some studies, the one randomized controlled trial that we see, about 40% of people get back to full activity. The most common complaint after knee replacement is still continued pain. And so we just have to keep those things in mind. And then we have to compare that to, say, the safety study that we did, which had 2,300 patients. essentially patients treated over a 10-year period that included autologous stem cell therapies for different orthopedic conditions. And the overall potential complication rate was 0.17, and these included things like swelling, temporary soreness, some inflammation, some stiffness around the joint, things like that. So because they're less invasive, obviously the door to the potential complications and the exposure to what those could be is going to be way smaller, right? So it's just a balance of all of those things. And so I say that just leading into, what Regenexx is. Essentially, Regenexx started in 2005, really looking at, some of the emerging research about utilizing different cellular-based treatments to treat orthopedic conditions. And these included platelets from your blood. These included stem cells from people's bodies that can be used in areas of degeneration, wear and tear, injury, just to help facilitate your own body's ability to preserve and maintain your own tissue. And the network has grown significantly to include, clinics all over the United States, as well as internationally. Regenexx Las Vegas is one provider in the Regenexx network. Obviously, we're here in Las Vegas, Henderson area. Again, I've been with them for roughly 10 years. But the overall process has always been starting with innovation, with the laboratory. So initially spent a couple years doing research, laboratory, how do we find cells, which cells are important, what's the dosing, what's the best way to concentrate them, how can we purify them, how can we improve that process over the years. And over the years, we've gone through different advancements of our laboratory processing techniques. We've always published clinical research. We track patients in a large registry. So we have close to 90,000 patients in an active treatment registry looking at complications, outcomes, success rates, those kind of things, candidacy. We use these when we see patients to guide treatment decisions. So that's what we'll talk about when we go through our process. And then we publish. So this is all important for education, transparency, advancing the field, providing more options to patients, and really just trying to advance medicine, specifically orthopedic care, and trying to move from more invasive to less invasive procedural options, where we're really just using needle-based procedures. We're using healing factors and components, and just precisely placing these into tissues that are compromised for one reason or another, whether it be from overuse, wear and tear, from injury, from mechanical overload, from supply and demand issues as far as how our bodies can maintain that tissue, and trying to improve them as best we can. And like I said, our whole philosophy is to preserve tissue as opposed to replacing it, cutting it out, or using things that destroy it over time. And so some of the things that are out there and available are called orthobiologics. And these are, again, taking advantage of natural healing mechanisms and components of those processes that we are very familiar with, because you still need them to heal from surgery. You need them to heal from injuries such as cuts or incisions, to heal from fractures or anything that is placed into the body to help stabilize. So our body has different mechanisms to address some of these tissue injuries. And not to mention, we're always having to turn over our tissue, our bone, our skin. All these things need to have some baseline reserve and reservoir for maintenance and repair. And so we're just utilizing some of the cells and proteins and growth factors that are already housed within our bodies, that we already have mechanisms by which they work and respond to our tissue signals. And these can be cells that we can get from your bloodstream. These can be proteins that we can isolate. We can get different types of cells like stem cells that are concentrated in different tissues like bone marrow. You can find them in adipose. You can find them in other sources. We tend to use a lot of cells from your own body, mainly because of some regulatory type stuff with FDA. But these are some of the things that we could take advantage of in order to help preserve your tissue. And so again, one cell we use is called platelets. When you concentrate platelets, that's called PRP, platelet-rich plasma. And as you can see, there's different growth factors that are housed within a platelet. And we can see that these could be really useful with trying to stimulate a healing type process, or improving blood supply to an area, or activating the growth of new tissue. So if we just look at the function of some of these growth factors, cell growth, generation of new blood vessels, collagen production, growth of new blood vessels, tissue repair, collagen production, healing, all these things. So these are activators of healing in your body. They have different functions as well, like clotting and that kind of stuff, to help stop bleeding. But can be very effective with different orthopedic conditions, to include mild to moderate arthritis, tendinitis, bursitis, small tears. And we'll see here in a little bit that the data and the research out there for these for different conditions is growing and has been compared to all of those other options that we discussed earlier that are given more traditionally, with a lot less potential side effects. A protein that we can isolate is called A2M, alpha-2 macroglobulin. It's a protein that helps bind inflammatory enzymes and chemicals that accelerate arthritic breakdown, or cartilage breakdown in arthritic joints. And so it's a cartilage preserver and protectant. And so we can use this protein in cases of degeneration, where there's a lot of swelling and response that way. And so that can be something to kind of rebalance your chemical environment in your joint to help, again, reduce inflammation and reduce the things that are destroying the tissue. And then kind of the thing that people hear a lot about are the key term stem cells. There's a specific name, mesenchymal stem cells. Some people call them medicinal signaling cells. These are kind of the things that you're thinking of when people are talking about stem cell procedures. Now, when you assess these cells in the lab, they do have the capacity to transform into different cell types. And as you can see, some of these cell types are all orthopedic based. So cartilage, bone, muscle, this is nerve. So these different types of cells can be important with maintaining and maintenance and improving orthopedic tissue. So things that wear down. So injuries to bone, cartilage breaks down. We get muscle tendon degeneration and tears. And so these can be very helpful in those situations, depending on the severity of the injury. And we can see that over the years, every circle or square accounts for different studies looking at stem cells for orthopedic conditions. This is a couple years old, but as you can see, it's grown significantly. Some conditions have more data than others. Bone marrow stem cell data, there's quite a few studies. A lot of the yellow studies are ones that Regenexx has published. If we look at PRP studies, I was saying that it's been compared. So there's PRP randomized controlled trials. This is comparing PRP to gel, saline, steroid, exercise, different types of regenerative procedures, medication, surgery, saline, steroid, et cetera, for all different kinds of conditions. So it's not like there's not data out there. It's just that, you know, some physicians aren't aware of it. Whether that be your orthopedic doctor or your internal med or family practice doc. Sometimes they're not as aware of this data, even though it's growing significantly with a significant number of randomized controlled trials showing benefit. So again, just all different studies for, say, specifically knee arthritis, where these things have been looked at and compared to other intervention. Now, having said that, you know, these types of procedures are also not the right choice for everybody. And so just like all medical procedures, people need to be evaluated for the appropriateness of that intervention for their condition. And so we have a process because we consider these medical procedures, and we need to understand the condition, the severity, and any other influences that could affect the potential outcome. And so we kind of, well, what I call the PPPs for success. We have things that we use to help try to predict and assess a person's candidacy. And then the rest of the ways to improve success is just to have a good processing and isolation of the cells, and then a good way to deliver precisely the product where you need them. This is just, again, to remind people that everything we do is orthopedic based. We don't treat other conditions, or, you know, with spinal cord injury, we don't treat central brain issues or other organ dysfunction. And so the prediction process is essentially made up of our evaluation, the fact that we track patient outcomes. So like I said, we have close to 90,000 patients we're tracking nationwide. And then being aware of research, our own protocols, and then what else is published throughout the world. So in general, you need to have a comprehensive evaluation in order to understand what's going on. So we tend to have about an hour-long consultation. I go through medical history, imaging. We feel that it's important to review imaging and try to educate patients on what's going on structurally, so they have a better understanding of why a procedure might help or might not help. And then this is also where we understand the physical limitations and the presentation, and then where we can have time to discuss options and develop a treatment plan. Sometimes the treatment plan is therapy and medication, sometimes it's referral to surgeons, and sometimes it's, okay, we think PRP, we think bone marrow with stem cells could be helpful, we think A2M, we think prolotherapy, we think something else is going to be helpful. So we try to educate people on all options to give them a good sense of what's available to them, and then go through that risk-benefit ratio. As I said, we track patient outcomes, so we do have all this on our regenexx.com website, where people can look at different parts of the body and look at pain, functional improvements. I think this is a little bit old, this graph. This is about up to 15 or 16,000 people now, but and it's out to about 6 years for most conditions. Again, we have our own published studies, our own clinical studies that we're performing, and then there's many studies, as those other slides show, that are being published throughout the world that we all need to be aware of as well. And all of that brings us to, okay, what is someone's candidacy status? Are they going to be a high responder? Is their characteristics of their issues going to make them a more moderate or low responder? And again, this is determined by imaging, exam findings, history, medical conditions, medications, as well as different parts of the bodies can have different levels of success. So for example, a hip joint on average doesn't have as good outcomes with the same amount of structural change as, say, a knee joint. And so we have to have those conversations where the conversion to surgery is higher for hip arthritis than it is for knee arthritis. And so those are just different things we converse about. during a consultation. Now, if someone chose to move forward with a procedure, again, trying to help preserve the tissue and strengthen it and do what we can to keep your orthopedic tissue healthy, we want to make sure that we're having and supplying the right dose for your problem. So dosing matters when it comes to PRP and different cellular-based injections. And this can be affected by someone's age, the severity of their injury, what type of tissue is affected. Is it your bone, your tendon, your disc? Is it a nerve space? And then it's nice to be able to make different products for an individual if they have different issues going on that would require different things. We do have a manual flexible lab platform where we have hoods and manual processing, and that's what gives us the flexibility to do all this. There's no automated machine out there that allows the flexibility that we have to create different doses for different tissue types based on age and severity, and to make all different products depending on what we're treating. For example, just like a typical spine injection, if we're injecting the nerve space, we'll use a solution called platelet lysate. For the joints, we might use PRP, very high concentration. For the muscles, we will use platelet poor plasma. And then they might all be different concentrations. So that's at least 3 different products of different concentrations that you might want to use. So a lot of people don't have that flexibility, and then it just comes at a little more limitation. And then obviously, once you understand the problem, you have the right concentration of cells, you just want to be able to deliver it to the right location. And so all procedures should be done with image guidance to ensure the proper delivery of the different products, whether it be a knee, shoulder, or, for example, the carpal tunnel nerve, the median nerve, utilizing ultrasound to see the needle, the nerve. That improves safety, it improves outcome, and it gives you the proper delivery to the problem area, as opposed to blind injections, which aren't always as successful. And so that's what we think is our difference, because we have all these processes to help better educate people so they go into it better educated, and then can come out of it with a higher chance of success given the process. When people go through different procedures, for example, this is just more of a basic overview webinar, but if someone's getting a PRP, or what we call our SCP, super concentrated platelets, these are typically 1-day procedures, but there's multiple parts where we have to do the blood draw, the processing, and the re-injection. Now, I always say that there's always some people that might need more than one treatment to get full benefit, even though the percentage of that are not super high, but that's always a possibility. There's always a little bit of stiffness and soreness post-procedure for a couple days. We tend to recommend some level of activity modification. Some people will be more, some people will be less. Some people need bracing, some people need physical therapy. Everybody gets follow-up every 4 to 6 weeks. Over the first year, we always follow up at least 4 times, if not more, if we need to. So we would like to keep tabs on how people are progressing with their condition. Sometimes the stem cell process, which we get bone marrow concentrate, which contains those mesenchymal stem cells, can be a little more involved. Sometimes we have a little pre-injection or a post-injection. Depending on the condition, you might just have a standalone treatment with the bone marrow concentrate. So there can be some times where there's a few things before and after to help kind of boost the pro-inflammatory and then help kind of feed things post-injection. We do isolate a lot of cells from the bone marrow. So that doesn't require a bone marrow aspiration, which is very well tolerated. We do have IV sedation and obviously local anesthesia capabilities. But we do all that stuff in the clinic, the labs here, all those things where we can count the cells, assess viability, know the dose, and be able to re-inject all in the same day. Now, we always just like to talk about, just like in the beginning, we have to understand that these are all tools that we can utilize to help people's orthopedic conditions, but not everybody's a good candidate. If you have just zero tissue to work with, it's not going to make your joint brand new. There are certain size tears, it's not going to help. So we definitely have to understand the limitations and when they can be helpful and when they're not helpful. And again, that's why we spend so much time with patients, educating them, walking through the imaging, discussing the options, so people can go into the procedure educated. Doesn't mean that you're going to get better because we have a good conversation, but people at least understand their potential. We've done our due diligence in understanding your condition so that we're trying to maximize the chance that people get better. All cellular-based treatments, human tissues, and cellular products are under FDA regulation and compliance. And so that needs to be taken into consideration. And that's one reason why we're not currently using umbilical cord stem cell products, because of their lack of FDA. Really, they're considered illegal in the eye of the FDA, which if you want to be around a long time, you don't get on the bad side of the FDA where they can take your license away. And so there's probably 100 or more warning letters to clinics and manufacturers discussing that. We can go into that more if people have questions about it. We've done studies testing certain umbilical cord products in the US and comparing it to just people's bone marrow, where in bone marrow you will get live cell growth and culture, and a lot of the available products in the US didn't have any growth. So we're not really even sure what to make of that when we try to test those products for purity and for their stem cell growth potential. There's been some recalls. This has been some years ago. There's limited data on the use of umbilical cord stem cells for different conditions. Again, if people have questions on that, we can walk through that. I do say that we do have other kind of modalities that can help with soft tissue pain and healing and inflammation. We do have the MLS laser, class 4 laser, that can be helpful. We do have hyperbaric oxygen therapy chamber that can be helpful for pre or post procedure, pre or post surgery, after injury. People use it for wellness, stress relief, exercise recovery, injury recovery, those kind of things. So there's data on some conditions, less on other conditions, but just things that we have that sometimes people want to add to their procedure or as a standalone treatment, depending on what's going on and what the condition is. So now I just want to take some time to go through any questions that anybody has. I am going to put the contact information for our call center and our education team. Danielle can help. This is her email, her phone number. If people have more questions on some of the things that we treat, if people have questions on wanting to send in imaging for a review to see is it worthwhile coming in to be fully assessed, then she can help with that whole process. And so she's available there. Let me see. I don't see any questions written down yet. If anybody wants to write some down, or if anything. Some of the questions we get typically is, can you treat more than one area at the same time? It's definitely possible. With PRP, you have a lot more potential. Sometimes with the bone marrow stem cell process, you might be limited to 2 areas just because of dosing. We're not allowed to amplify or grow your cells over time to allow us to treat more areas with a higher dose. We're really constrained through compliance guidelines. And so these are all same-day procedures where we're concentrating and isolating, but we're not amplifying or culturing. So it's usually 1 to 2 joints. Most PRP or bone marrow derived stem cell studies are not covered by insurance. Regenexx is the only organization that has some coverage through self-funded employers. And so we have greater than 2,000 companies that are contracted with us where people can utilize as just like their insurance. And so depending on where you work, you might want to inquire about that. Question, when are appointments available? Well, we have clinic Monday through Friday, 8 to 5. So it's just a function of calling and seeing what's available. We try to do procedure days, Tuesday, Wednesdays, and Fridays. They're not always full of procedures, so sometimes there's availability on those days as well for just new consultations. So Danielle can help you get scheduled or at least give you an idea where we do telemedicine visits through via Zoom or other means, or we could do them in the office. Imaging is helpful. I can order imaging. I can assist with that. If you have imaging within 12 months or really any recent imaging, you can bring that in. Some conditions need MRI. Some are okay with X-ray or ultrasound in the clinic. So it really just depends on what's going on structurally, the location, the symptoms, and that will help determine what type of imaging is needed. We are contracted with different insurance companies for the consultations. So a lot of times that's covered. What recommendation exists about the use on facet disease and disc pathology? Yeah, I mean, a lot of it depends on the severity. If we're catching facet issues and disc issues early, we use PRP a lot on that. There's quite a few studies on intradiscal PRP as long as you're using a high concentration. And we're using more of a leukocyte-rich PRP. It can be pretty helpful. Disc issues can really be, we basically look at how much disc height is left, how big are the herniations or bulges, and then if you've lost a certain amount of disc, then it's kind of hard to change that. If you still have well-preserved disc that has some bulging or tearing, then there's good outcome for that. We utilize a lot of PRP. Sometimes we'll use bone marrow concentrate. Facet disease, if you have more severe high grade, then we might be more aggressive. Where mild to moderate, grade 2, grade 3 arthritic changes, then PRP high dose can be pretty successful for that. So, as with most things, it really depends on the severity, the amount of tissue. Joint issues in the back can develop a lot of bone spurs, and so we want to make sure we can access the joint and get where we need to, and that's where the MRIs are really helpful for the low back or neck or wherever the disc or joint problems are. Okay, bone on bone, pain in my shoulder, no cartilage left. Does cartilage grow back even a small amount? If you're 100% bone on bone, we don't expect much cartilage growth. Now, there have been some knee studies with arthroscopy follow-up that have shown some patchy growth in some studies, but we don't expect a significant amount of cartilage. Having said that, with shoulders, now it really depends on how bad it is because there's definitely a spectrum. Some people can have focal bone on bone versus diffuse bone on bone. So you can have patches where there's no cartilage, and then in between those patches, there is cartilage. And then sometimes if you're really bone on bone, then you tend to have a lot of bone spur formation. So we like to assess what's your range of motion, what does the cuff, the rotator cuff look like. So you can still get improvement through affecting the chemical environment of the joint or treating bone overload in those conditions. But it really just depends on the severity of what the bone looks like. Is that breaking down? Do we see any type of tissue that can be improved? We've treated many bone-on-bone shoulders, but there's definitely some that we're not recommending a procedure. And success rates can definitely be a little bit lower as it gets more and more and more advanced. So, but if it's a full widespread bone on bone, we're not going to necessarily expect that much cartilage change in those joints. Are some of the items like therapy, x-rays, MRIs covered by insurance? Yes. So all traditional stuff, MRIs, medications, steroid injections, if we did gel injections, if we sent you for imaging or therapy, if we're contracted with your insurance, consultations, follow-ups, all of that stuff can be covered through your insurance as long as we're contracted, as long as they approve. And it's still subject to your deductible, your co-insurance. So it doesn't mean there's no out-of-pocket expense, but it just depends on how your insurance is structured. How often do you recommend to apply PRP to tissues? Really just depends on severity. So like for example, spine injection, spine has a little bit higher repeat rate of injection, about 30%. Most people with one treatment can get years of improvement, but there's probably 3 out of 10 that might need to do a couple up front to get that extended benefit. Most joints are going to do well with one, but there's always a percentage of people, 10 to 20%, that it takes more than one to get to a good sustained benefit. And then you have to think about what's the condition. Do you have a degenerative condition that we're just maintaining and preserving and improving pain and function? Or do you have a small tear that can heal? And then if it heals, then that can last your lifetime. If it's a degenerative condition, then you may have some maintenance in the future, maybe 2 years, maybe 4 years, maybe 6 years down the road. But as you continue to be active in a degenerative situation, there may be a return in symptoms at some interval. So that interval is going to be variable. On average, PRP for an arthritic joint, as long as it's in that grade 1 to grade 3 range, you can get a couple, 2-3 years out of it easy. Some people longer. Some people less, obviously, but if you looked at the averages, and then it may need to be repeated depending on your activity, your symptoms, those kind of things. So just remember to take down Danielle's information if you guys have more questions that come up. I'm not seeing anything else pop up in the moment. Again, reach out to us if you have more questions. There's really no downside to a consultation, just to understand all of your options, your candidacy. Obviously, not everybody comes in and moves forward with procedures, and sometimes we're sending people off to do other things, but you at least get a good sense of what all options are, what the potential for improvement is, and then from there, at least you understand what they are and can be better informed at making the right decision for your orthopedic condition. So I appreciate your time. I'm not seeing more questions. I'll let you guys get back to your evening. We try to have these at least once a month. A lot of times we'll start trying to change it up to be more specific. Sometimes we'll do a low back webinar or a knee webinar, or we're going to make some to get a little bit deeper into what PRP is and what factors may influence outcome. So just keep an eye out for those. But otherwise, appreciate your time and have a good night.